Okay, so we're doing a physical examination lecture, and we're actually just like almost like a day kind of ahead. So I believe this is actually slotted for Wednesday the 5th, but this is going to be your Monday, day 4, because we do start it on that first day. So we did our vital signs lecture. I hope you've had a chance to go through the PowerPoint again. Make sure you go through chapter 4 in Wilkins. So then generally after the lab, I end up in the class when we're in a normal campus, and I go ahead and we start this PowerPoint. It's got a lot of information. I would definitely look at chapter 5 in Wilkins and then chapter 16 in Egan's. I have these pages noted. This will not be part of exam 1, which you will have on Wednesday, August 5th. I also know we're on campus that day doing your cultural presentations, but the exam will be open all day long. And then the following week, on the 10th, is actually when we're going to be doing some Chekhov stuff, where you can do some hands-on with this material. So, and we revisited again also an advanced patient assessment. So, it's just, like I said, it's a lot of information, but we'll just get through it. So when we're looking at our physical exam, our initial exam obviously is to kind of like confirm information that's gathered during the interview. Does it match up? Does it not? And it kind of gives us a baseline, basically, of what's going on with our patient at admission. Okay, hopefully, for example, if they're having accessory muscle use on admission, that's something we're hoping to correct or improve, make better for them. And then the subsequent exams then are basically used to help us evaluate our treatment and see how the patient's status is doing. Are they getting better? Are they getting worse? And then we go from there. So there's several different components. There's 4, and we'll talk about each one of these. So we have the inspection piece, which is just your kind of looking at, kind of hands off. You're just looking at the patient, general appearance. Palpation, that's kind of more feeling around, making sure you have bilateral expansion, and we're going to go through each one of these in more detail. Percussion, and then auscultation is actually listening to our breath sounds. Okay, so on that first part of like kind of inspection, so we're looking at our patient, observing their facial expression. Are they showing pain, fear, anxiety, grimacing, crying, whatever your more classic signs in their facial expression. We're looking for increased work of breathing, so things like increased respiratory rate, accessory muscle use, cyanosis, the discoloring, the bluish kind of hue, nasal flaring. You see that more so in children. Pursed lip breathing in our COPD and asthma patients, more so COPD. And then their patient position. Are they tripoding? And we have examples of that here coming up. Okay, so I also want to include this slide about the eyes, for examining the eyes. So you'll definitely see the physicians in the ED look at people's eyes. They're checking basically to see if they're this PERLA. So you need to know the acronym for this, PERRLA. So whether or not the pupils are equal, round, pupils are equal, are they round, and are they reactive to light and accommodation? So basically, so they'll shine the light in their eye, their pupils should constrict, and then when they take the light away, they should dilate back again. Okay, so the diagram there, this woman obviously has unequal pupils, pinpoint being in her right eye, and then dilated would be the bigger one on her left eye. And then just a couple different abnormalities and what they might be caused from. Mydriasis would be fixed and dilated. That's something that they look at to to see if they're brain dead. It can also be caused by catecholamines and atropine. So if you have your eyes dilated, they generally give you atropine drops, and that dilates your eyes so they can do their eye exam. Meiosis is pinpoint pupils. You'll see that with patients that have been on opiates. Ptosis is the drooping of the upper eyelid caused by neuromuscular diseases such as myasthenia gravis. And then nystagmus is an involuntary cyclic moving. It's also something that when I guess you're pulled over, they assess for drunk drivers too. So on your left there, you're seeing some cyanosis, the discoloration of their fingertips, and then that gentleman there is tripoding. He's kind of leaning forward. So basically, like his chest area would be like the point of the triangle, and then his left and right arm would be like the lower angles of a triangle. That's where they kind of get the word tripoding. Sometimes patients will do this with their bedside table. They will sit at the edge of the bed or possibly in the chair like that, and they will even lean more forward, propping their elbows on the bedside table to kind of help lift their diaphragm, because their diaphragm is flattened. It's not moving as it should, from overuse, and then it's kind of helping. They'll use more of their neck and shoulder muscles, their intercostals. They'll use those accessory muscles to help them breathe. So again, on part of our assessment, we should be looking at the tracheal position. We want to make sure that that is in the center, in the midline, that there's no deviation. If there is deviation, then we kind of have to look to see like what is causing that deviation. It could sometimes be like a mediastinal or a tumor possibly in the trachea area, but the other thing that we're concerned about is a pneumothorax. So if we have a trachea shift towards a side with reduced lung volume, okay, that's going to happen where possibly there could be like a little bit of a pneumothorax, not a tension pneumo, and I'll explain that in a minute, or atelectasis or lung removal. So there's part of the lung that's gone, so the trachea is going to shift towards the side of that reduced lung volume to kind of help occupy that space, because it's basically empty or less. And then a tracheal that shifts away from a tension pneumothorax, because a tension pneumothorax is from positive pressure inside the chest wall, so it's kind of pushing away from the affected side. So if you have a tension pneumothorax on your right lung, it's going to push everything towards your left side. So your trachea is going to be pushed on your left side, because that tension, that pressure is pushing everything on your left side. And that can also occur with a pleural effusion or a tumor. When I was talking before a lung tumor, I was talking about a tracheal tumor or something that might be pushing your trachea. But so in your lung, you could have fluid, or you could have something occupying that space like a tumor, and again, it's going to push away from the affected side. The other thing that you look for is jugular vein or jugular venous distension, or jugular venous is caused from jugular venous pressure. Basically, it's reflecting the volume and the pressure in the right side of the heart. So when there's increased venous pressure, then these neck veins, like your internal jugular, it might distend. So it's called JVD, jugular venous distension. It can indicate right heart failure, which is otherwise known as cor pulmonale, and you might see a little bit of a fluctuation of it distending and then not distending, and like the column of blood will fall during inspiration, and then it should kind of resume the position of the blood being filled again during end of exhalation. So that's actually when you do a CVP measurement, when you have a internal line, central venous line, your CVP is basically measuring your right atrial pressure. But that's a time when you're going to want to know this on an exam, not for you guys quite yet, but the CVP is always measured at the end of exhalation. Okay, so what happens is you may develop right-sided heart failure, can actually occur secondary to left-sided heart failure, or from chronic hypoxemia. So hypoxemia initiates the pulmonary vasoconstriction. So when we have low oxygen, the vessels in the lungs actually vasoconstrict as a reaction to it. And what happens then, you think about Pazzel's law, you think about that narrowed tube now, or the narrowed vessel, trying to get the blood through it. It's going to increase that resistance. Okay, so it's going to need more pressure. So it increases the resistance to the blood flow through the pulmonary vasculature. Then what that's doing is it's increasing the workload of the right ventricle. Okay, so your right ventricle has to pump harder because there's vasoconstriction going on in the lungs. There's that pulmonary vasoconstriction. The vessels have tightened down, they've clamped up from the hypoxemia. That's why oxygen helps vasodilate, helps relax the vessels so that the oxygen can obviously get in there, but that's part of the treatment. That's why oxygen will help also reduce the workload of the right side of the heart. So when you have persistent lung disease with hypoxemia, you may develop right-sided heart failure. So your right side of your heart is not pumping as efficiently as it should, so the blood kind of tends to back up, and it backs up in that jugular venous distension and causes jugular venous distension. So basically that internal jugular then will distend because of all that volume that's kind of backed up from the right side of the heart. My dogs are being total butts today. Okay, never fails. Okay, so here's just again a couple different pictures of the JVD that you'll see. I know for sure one of these is in your textbook. There's also a great resource that I put at the very last page of this presentation. That's a really good resource from the University of San Diego, so I highly recommend that you check that out. All right, accessory muscle use. So that's the other part that we can do with inspection. We're seeing whether or not they're using these accessory muscles, the ones in their neck, the sternocleidomastoid or their scalene muscles. Again, these are common with obstructive disorders such as COPD and asthma. They may, be kind of more pronounced from overuse. Also, chest inspection. So we're, trying to have the patient sit up as upright as possible. So we're trying to evaluate that anterior posterior diameter. And with the overuse of these accessory muscles with our COPD patients, they end up developing an increased AP diameter. Okay, that's what kind of creates that barrel chest. So the anterior posterior, generally it's narrow in a normal person. You can see how it's gotten widened, how it's widened out. Okay. So just look and see what the dog's chewing on. So again, the increased AP is generally referred to as barrel chested. So what's happened here is that the natural recoil properties of the lung have decreased. They're no longer able to recoil like they're supposed to due to that air trapping that develops, that the hyperinflation, the overdistension of the lung tissue ends up trapping that air, and so they no longer recoil, and then the muscles, the rib cage, tend to move outward. As the loss of that lung elasticity happens, the ribs move outward, which then leads to that barrel chest. Again, also it affects the diaphragm because it pushes down on it, so that's why they appear to have a flattened diaphragm. And then the ribs actually move more horizontal, so they move kind of more sideways. And we'll talk about a Hoover's sign. I'll talk about that coming up here in the actually, you know what, I might talk about it now, the Hoover sign. So what happens, and this is on page 80 in Wilkins, so because there's this additional chest movement because of the loss of the diaphragm, so the diaphragm is just kind of like sort of flaccid. It's just kind of no longer contracts and expands. It just kind of lays there kind of flat. I mean, it still moves, but it's really limited. So COPD patients with the severe hyperinflation, again, have the low flat diaphragm with limited mobility. So the contraction of the flattened diaphragm ends up pulling the lateral margins, okay, so on the side of the chest wall inward, actually, during inspiration. And this abnormal movement of the lateral chest wall during breathing in the COPD patients with the severe hyperinflation is known as a Hoover sign. So again, page 80 in your textbook. And I believe maybe one of the links from the video might, or from the PowerPoint might show you that. It's kind of different. You can Google it if you can't find it. I can't remember offhand. I haven't clicked on all these links again, but there are several different links. So you also want to know this for sure, your chest inspection and what it means, what all these different curvatures or chest or spine deformities mean. So you have scoliosis there on your upper right. So scoliosis is basically like an S, okay? You have like this curve of your spine, okay? So it's just like a snake, S. And your kyphosis then is more of like kyphosis or a camel. It's kind of have more of that hunchback or roundedness. And then kyphoscoliosis is basically both of them combined. You have both. You have the hunch, so you have the kind of like the camel back, and you have a curve. Okay, so make sure you know the differences between the terminology of those. The other things that you can see are whether or not they have pectus carinatum, whatever, pectus carinatum, I think, which is referred to as a pigeon chest, kind of a forward projection of the xiphoid process in the lower sternum, which is on the left side. So he has it fairly pronounced there on that very left side, and then looks like he might have had a procedure done. They can actually do a surgery for that and reduce that, and sometimes have to put staples or a plate or something in there. And then pectus excavatum then is a depression of the sternum. And one way to kind of, pectus carinatum is PC, pigeon chest, and then excavatum, I always think of an excavator like with a scoop on it, scooping out, so it kind of scooped out the chest. Other thing that you're going to be looking for, especially if in a trauma patient, to see if they have a flail chest. So a flail chest is where the chest moves in on inspiration and out on expiration. It's generally caused from multiple rib fractures at one or more sites, and can cause like a paradoxical breathing, so almost like a seesaw breathing. So it's not synchronous. It's kind of off kilter. So make sure you check up, click on both of those YouTube video links to see examples of that. The other thing that you're looking at are to make sure that your breathing pattern is regular. You're looking, is it regular, is it rapid, is it shallow? The I to E ratio, that means the inspiratory to expiratory ratio. Generally, you should have like a 1:2 ratio. So inspiration is shorter than the expiratory phase of our cycle. So retractions then would be looking at the inward depressions of the skin that's kind of in between your ribs there. So if that kind of sinks in, it's a little bit difficult to see in obese patients because they have too much padding, but with children you can usually see it pretty well. Sometimes with adults too. So it's called intercostal retraction if it's in between the ribs. If it's below the ribs, it's called subcostal, and if it's above the clavicles, it's called supraclavicular. Sometimes there also can be like a tracheal tugging, which is actually kind of like right above your sternum area, there where you have that little depression there in your neck. So you follow your trachea down, and then kind of where you have like where your clavicles kind of meet, right above your sternum. Abdominal paradox, that again is kind of like similar to the seesaw breathing, where you have the inward movement of the abdomen when inspiration. We'll really look at patients that when they're weaning, if they present with abdominal paradox, because it can lead to diaphragmatic fatigue. So you really want to make sure that they're being synchronous with their breathing. So just a little side note, the diaphragm then in your intercostal muscles, so I mean we use our intercostals, but if it's really sinking in, then it's called retractions, because our intercostals are part of our primary muscles of ventilation. Men typically breathe with the diaphragm, causing the stomach to move slightly outward during inhalation. And women tend to actually use a combination more so of the intercostals and the diaphragm, producing more chest wall movement really than men. So just kind of like a little side note there, a little trivia. All right, so when we see abnormal breathing patterns, whether it's well, pretty much these things that I'm going to talk about now, but it's kind of like, why are they breathing that way? Okay, so we kind of have to like recognize certain breathing patterns that are associated with different types of disease processes or injury or illness. So when we look at rapid shallow breathing, it's kind of more consistent with restrictive lung disease. So again, restrictive lung disease basically is something that physically this is how I kind of keep it straight in my head. I mean, I got it down now, but when I was first learning it, restrictive, I kind of think of like a girdle or a corset that they used to wear in the olden days, those things that they kind of really limited the chest wall movement. Okay, so things that are kind of, I don't really want to say mechanical, but it's not really, it's just a different way of looking at it from obstruction. So scoliosis, obesity, okay, so those things are actually restricting the capacity, the ability of the chest wall movement. Interstitial lung disease, because the lung tissue gets stiff, okay, so anything that's really going to limit the movement of the chest. So obesity, scoliosis, what was I just thinking of something else? Oh my goodness, can't remember. Yeah, if you're wearing something really super tight and you can't breathe, I guess. So when we're looking at prolonged expiratory time, is consistent more so with intrathoracic airway obstruction. So that's more like in the lungs itself. Okay, so post polio would be like another restrictive lung disease. I think I've told you guys about my sister Jeannie. She's got obstructive and restrictive because she used to be a smoker. So, but again, that restrictive, so like post polio would also do it. And she also has kyphoscoliosis, so she's got both. So then prolonged expiratory time. So then you're kind of looking to see, are these patients a COPD patient, an asthmatic patient? Why are they having the prolonged kind of might not really necessarily be affected by a wheeze, but they just need a longer time because of that air trapping on expiration. A prolonged inspiratory time, so there's some type of upper airway obstruction. They're trying to pull in longer than normal. Croup and epiglottitis would be an example. And any use of accessory muscles is definitely indicating an increased work of breathing. And again, we're looking at are they using their intercostals, their scalenes, their sternocleidomastoids, their pectoralis, more of their chest, the trapezius, your abdominal wall. So we're just trying to see what the deal is. Some of the neuromuscular diseases, and your COPD patients for sure use the accessory muscle use. Okay, so here is a little table from chapter 5 in Wilkins again. Just kind of seeing like if they have this, if they're presenting with this, you know, the name of it, what characterizes it, and what could be the cause. So apnea, obviously you're not breathing. Cardiac arrest, respiratory arrest. Biot's breathing, it's associated more so with like intracranial pressures, increased intracranial pressures, where you have irregular breathing patterns and then you have these long periods of apnea. Okay, so you're thinking more of a head injury. Cheyne-Stokes breathing, that is again an irregular type of breathing. You kind of increase, the breathing increases the rate and the depth, kind of like in like a pattern, kind of slower, then bigger, and bigger and bigger, then they go apneic, and then it repeats itself. So that can be diseases of the central nervous system, or CHF. Kussmaul's breathing is just more deep, fast breathing without that apnea, and it could be like a diabetic patient if they're in DKA or metabolic acidosis. Apneuristic breathing is a really prolonged inhalation, almost kind of like a kind of a weird thing that they'll do, and that can be brain damage. Paradoxical again, where a portion of the chest, portion or all of the chest wall moves in with inhalation, out with exhalation. Chest trauma, diaphragm paralysis, a fatigued diaphragm. Some people that have had surgery or different injuries or something, they may actually develop like one part of their diaphragm or part of their diaphragm, either like their left or the right side, or even just part of it may have they may have diaphragmatic paralysis. And then again, that prolonged exhalation, not only just your asthmatics, but again your COPD patients too. So respiratory alterans, that's just another one I kind of have written down as a side note. That's when you're switching between accessory muscles only and diaphragm only. They mention that in your textbook. Again, here's some different video clips. I highly suggest that you watch them so you can kind of see what we're talking about. Right. Palpation. Now here is kind of where we're actually using more of our hands to kind of do the examination part. So this generally is looking at thoracic expansion, and the next slide will kind of show it a little bit more, but I just want to talk about this first before I move on. So basically both sides of your chest wall should expand evenly. You should have it bilateral evenly expansion, okay, with normal or deep breathing. So you should have, both your rib cages on both your left side are going to expand. One side might underexpand if you have atelectasis and pneumonia, some consolidation, or maybe a tumor. Okay, both sides might expand poorly with emphysema because again their diaphragm doesn't function as well, and so you're not going to see as much movement. So what you really do is, and this is why we're going to go back in the classroom here on the 10th to kind of practice some of this stuff. And if you want to, I advise you to try doing it at home and a family member or friend or whatever. So you place both of your hands at approximately T8, kind of right below the scapula there, and you have your thumbs, touching. Okay, and then you have them take a deep breath, and your hands should move outward. Okay, you keep them placed on the body, but as they take that deep breath, you should have about a 3 to 5 centimeter movement excursion. So what, about 1.5 to 2.5 on each side, and your hands will just kind of move out a little bit. Okay, so if you don't have it equal, so if you're suspecting something on one side, the side that's affected is not going to move. Okay, again with the COPD patient, it's going to be both sides, so you're just going to have a little limited movement. But if you have a pneumonia or a tumor or atelectasis or something on the affected side, that side's not going to expand quite as well. So that's thoracic expansion. palpation is another thing that you can do, and it's related to kind of feeling the vibrations that are created through your vocal cords. Okay, so you have vocal fremitus and you'll have tactile fremitus. So your vocal fremitus then again is the vibrations through your voice, through your vocal cords. So the vibrations that are transmitted, so that's like when you listen to somebody and they're talking, you can hear it all the way through their lungs. So you ask them not to talk because it's really interfering with you trying to do your assessment. And then coughing also is, I mean, sometimes they can't help it, but it'll be very loud when they cough and you have your stethoscope in. Because these vibrations then are transmitted throughout the tracheobronchial tree, through the alveoli, into the chest wall. These vibrations are actually felt with your fingertips, it's called tactile fremitus. So sometimes we have patients that are really coarse, raucous, like kind of gurgling almost, like patients where you just want them, you want to cough or you want to cough for them and they're having a hard time mobilizing their secretions. You can actually sometimes feel it on their chest. Okay, so that's tactile fremitus. And tactile fremitus can be increased, decreased, or absent. So I always think of it as it's going to increase when it has like a median or something to travel through. Okay, so an increased fremitus then is any condition that's going to increase basically the density of the lung. Okay, so you have like a consolidation there, a pneumonia, you have atelectasis, it's not filled with air because the lungs are collapsed down, so it's just more lung tissue. Sometimes there's secretions related to the atelectasis, a tumor or a mass. Okay, so some type of medium that allows that vibration to travel. So decreased or absent then is when there's kind of like nothing there. So like a pneumothorax, there's just air there, so you're not going to feel anything. There's pleural effusion, so there's fluid there. There's bronchial obstruction with a mucus plug, so beyond that mucus plug there's no air going in there. COPD, the air is just not moving. So those types of things. Muscular chest or obese chest wall, again, not really moving, a lot of air, or you're in those cases actually usually can't feel it because of the increase of the tissue. And then the rhonchi fremitus, that's kind of what I was referring to, when they're really filled with secretions. Okay, so that would definitely be increased because you can definitely feel it. All right, so palpation, the other thing that we can, see with looking at the skin is the general condition, whether they're dry, temperature, if they have a fever. But subcutaneous emphysema is a really kind of cool little thing that you run across now and again. And a lot of times it's related to them having a chest tube or pneumothorax. So there's air that actually leaks from the lung into the skin, and it feels like you're slowly kind of crushing bubble wrap, like really small pockets of bubble wrap, real small ones, not the big ones. And you're kind of walking your fingers across the skin and you can actually feel it kind of popping. Percussion is another technique that we can do to help evaluate what's going on with the lung tissue. This actually takes quite a bit of practice. It's a technique that you kind of have to develop, and again, watching these YouTube videos can help demonstrate it since we're not in class. But again, this will be something that we will practice when we go back into the lab. So basically you kind of put your, let me see if it's on the next one. It's really not. I thought there was maybe a picture of it. But you use your hand. So you put your hand, one of your hands on the person's chest, like the upper, like if you do it like around a bone. So you have like your middle finger lying across a bone, basically, but your whole hand is flat. And then you take your other hand, I don't know if you guys can hear me, I'm kind of trying to do it, but then you take your other hand and the point of your middle finger, the tip of your middle finger, you kind of just wrap it against that first knuckle of your middle finger. You just kind of hit it, kind of a quick flick of your wrist, and you just kind of like I'm doing it on the desk right now. So you're looking to see what type of sound that you can create. That vibration is actually kind of penetrates about 5 to 7 centimeters below the chest wall. So it's going to sound different if you do it over a bone compared if you do it like over your belly, because your belly's, you know, either hollow or kind of air filled. It's, you know, it's more of a, or if you do it against your cheek, that's a good way to do it. Blow up your cheek and do it that way. Again, we'll practice in the classroom. But watch the video clip because that's kind of fun to see how they do that. So what it means is if you have a normal resonance, that's just low pitch sound that can easily be heard over normal lung tissue. If you have hyperresonance or increased resonance, okay, that's kind of more like a drum hollow sound. Okay, so hyper or increased is more, you know, just think of hollow. Okay, so you have like a pneumothorax, you have a COPD patient, the hyperinflation, your stomach, your cheek, okay, your cheek that's inflated with air, puff out your cheek and try doing it. So that's the hyperresonant sound or increased resonance. The hyporesonant sound is kind of like what I would do over my desk. It's just flat, dull and flat. So it has a density to it. They're like a pneumonia, an atelectasis, a pleural effusion. Okay, it's generally easier to kind of detect if you have it on one side. If there's like a abnormality on one side compared to the other, so you can kind of compare both sides. Okay, so you have one side that sounds normal and the other side that doesn't. You have that contrast that you're able to compare to. And there is actually a little link on here, not quite as visible, but if you go to the regular PowerPoint screen, just the regular PowerPoint without the audio, click on that link and there'll be demonstrations again and examples. Alright, this is just again a little anatomy of your stethoscope. We got a chance to use them the other day in lab. Again, your earpieces, they kind of, if they, you know, you hold your stethoscope with your earpieces pointing kind of forward. That's, you know, it should be pointing towards your nose, so that's how you should put them in your ears. Your diaphragm is the kind of flat part that you're listening through, so always make sure. The other part's called the bell, and that those can usually, you know, turn around, so you want to make sure that you have your diaphragm flipped the right way so you can hear properly. Alright, and this will also practice this when we are in lab. So breath sounds are kind of tricky. They take a little bit of time to master. I just did a lecture with the advanced patient assessment group, and we will listen to the hopefully you guys see they haven't gone out at all to clinicals. Things have been delayed with them because of COVID, so they haven't even gone out to any patients. They haven't done their first rounds at all, so they have nothing really to even compare to. Generally, when I do that advanced patient class, those students have already gone out to their first round of clinicals, their floor rotation, so they kind of have some more, you know, they have the ability to connect the dots a little bit more. And these guys, they are set up though. They're going to be going out in September, so I'm excited for them. So hopefully things will get a little more settled by the time you get to that point. And I do have a really nice DVD that's an, you know, audio and visual that kind of shows you, gives you a little bit more visual breath sounds too, as far as well, I'll talk more about it later, but we'll listen. You've got some, yeah, you've got a couple different links. I know for sure one here, but we will definitely have chances to listen to other breath sounds. But let's just kind of talk about how we're doing our assessment first. So you want the patient to be sitting upright. You have them breathe a little bit deeper than normal. Ideally, they kind of like you to start at the bases, so start at the bottom part of their lungs and then work up towards the apices. The idea with that is that if you have them take a bunch of deep breaths, the atelectatic areas, the areas that are maybe slightly collapsed where you might hear a crackle or two, will have expanded by the time if you start with the apices and work your way down. That's kind of why they want you to start at the bases. Practitioners do different things, just whatever they feel comfortable with. So you're basically always working your way left to right, or right to left, however, but you're kind of comparing your left side to your right side and your left side to your right side. So you want to listen for sure for at least one full respiratory cycle at each point of auscultation. So you want them to take a deep breath in and then exhale. Okay, then you move your stethoscope. And we'll practice this again in the classroom when we meet on the 10th. So there's 12 basic areas to be auscultated, 6 in the back, 4 in the front, and then 2 lateral. So you're listening to make sure that there are indeed breath sounds, and if there's any adventitious sounds. So adventitious sounds is basically anything that's out of the ordinary. Okay, one time I was talking to my daughter's pediatrician. She was young and she had a little bit of asthma, but she never really wheezed. She was just more of a cougher, and sometimes she'd be a little diminished. But I was talking to her pediatrician and I said, but I've never really heard any adventitious breath sounds. And she's like, excuse me? And I said, I've never heard adventitious. And she goes, you have to tell me what that means. I was like, seriously? I mean, she knew what a wheeze and a rhonchi and a rail, I mean, she knew what those all were, but she'd never really heard, I guess, the term adventitious breath sound. So I always think that's funny when I think of that word. Okay, so you'll hear bronchial or tracheal. They can be referred to as either. I think you'll hear them both, I guess, as far as the terminology. It's the same thing. So they're the sounds, and you can do it, you can listen, you have your stethoscope. So, again, bribe a family member or friend or something and say, can I practice on you? The sounds that you hear over the trachea or the large airways, they're generally loud, they're higher pitched, and they're an equal length, meaning during inspiratory and expiratory, they should be about the same amount of time. Okay, so if you have a tracheal or bronchial breath sounds, that's generally where it's heard. Now you can actually hear what we usually refer to more as a bronchial breath sound out into the lower part of the lung, and generally that can indicate some type of a consolidation of like a pneumonia, or they might have a bronchial where the tube is still paying with the air, but the tissue around it can cause that more bronchial sound. We'll talk much more about that later too. Bronchiovesicular breath sounds are heard more so in the upper part of the sternum, kind of between the scapula. They're quieter than tracheal sounds, but otherwise they're pretty similar. Okay, they're kind of like the medium in the middle. And then your vesicular breath sounds are what you're going to hear out in the periphery of the lung, and that's what normal lung sounds sound like. It's kind of a softer sound, a lower pitched, a little bit muffled. It's definitely lower pitched in intensity than your tracheal or bronchiovesicular sounds. You're going to have a longer inspiratory than an expiratory. And when I was referring to about that DVD, is that it, oh, and I'll tell you guys about this too. Hold on one second. Okay, so it gives you a nice visual as far as showing that longer time on inspiratory, or is it going to be on expiratory, depending on the breath sound, especially the adventitious breath sounds. Okay. All right, and there's actually like a little diagram in the book that kind of shows you that too. It's just kind of like a little, like a V, kind of like it's shorter in inspiratory, longer in expiratory, especially if it's like a wheeze. So make sure you click on that link here on this page. So Again, those normal vesicular breath sounds, like I said before, can be replaced with that bronchial sound when lung tissue density increases. Okay, so when normal air-filled lung tissue becomes atelectatic or consolidated, like in a pneumonia, the breath sounds can be really similar to what you might hear over the large airways. Okay, so it's not normal to have those bronchial breath sounds out in the periphery. Atelectatic is generally more associated with the crackles, but I've always taught that if it was bronchial, it was more like of a pneumonia. Okay, so another way of describing breath sounds, it can be harsh. That would mean that they have kind of an increased intensity. Diminished breath sounds, meaning you just don't hear them very loud, or they can even be totally absent. Okay, totally absent is alarming, especially if they don't have like a history of part of their lung removed. So, you know, not to raise any red flags and get them all excited, but like, I don't really hear your lung sounds as well. Have you ever had surgery? Look at your chart, though, again, before you see your patient. That can give you some, heads up to that. So, put yourself in an awkward position. But sometimes, especially if they are presenting with shortness of breath or something going on with them, it's very well that you might hear absent breath sounds. But diminished is actually really common with the COPD patients because they're hyper-expanded, they're hyper-inflated, so they're kind of air trapping, so there's not a lot of air moving back and forth, so they often have diminished breath sounds. Okay, adventitious breath sounds. I'm seeing if I can keep this under an hour. I'm probably going over, I bet. So adventitious breath sounds then are basically kind of those extra sounds. Okay, so they're any type of sound or vibration that's being produced by air moving through abnormal airways. Okay, so they're like an extra sound basically. And they're generally classified as either continuous or discontinuous. And again, that DVD kind of can show you like a little visual as to what that looks like. Continuous means it's just you hear it throughout. You just hear it continuously. It doesn't like come and go. Okay, it's not like an occasional intermittent or interrupted sound. It's just like a wheeze is a wheeze. You just kind of sound. Coarse crackles, or otherwise known as rhonchi. I think some of these breath sounds, I think part of the confusion with it is that what people call them. Different practitioners sometimes call them different things. So coarse crackles basically is rhonchi. I went to school in the Midwest. I worked there for about 5-6 years before I moved out here, and I kind of learned rhonchi. When I came out here, people called it coarse crackles. So it's really the same thing. It just depends. I think it's kind of regional, really. Discontinuous. So discontinuous is kind of more like intermittent. So I like fine crackles. Okay, you kind of think of them as like little pop, 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 pop. Fine crackles or rails. Okay, I again kind of grew up or whatever, was raised on the rhonchi rails terminology. Seems like out here it's kind of more coarse crackles, fine crackles. So those are generally associated with, can be fluid, and it can also be atelectasis. So those little lungs are kind of popping back open. So just like really short, kind of intermittent. So they're discontinuous. So all the different types of breath sounds that you could hear. Again, crackles, wheezes, stridor generally is kind of transmitted through the lungs, but the site of origin is generally the upper airway in the throat. So like epiglottitis, croup, that's kind of more of that kind of sound when they take a breath in is stridor. It also can appear right after you've extubated a patient, after you've taken out the breathing tube. If there's some airway swelling, they may have stridor. And if it is severe enough, you may have to reintubate. Diminished breath sounds, absent breath sounds, and then pleural friction rub. So normal breath sounds are a good thing, good air, hopefully is exchanging. Diminished breath sounds, again, suggest shallow breathing or hyperinflation, again with our COPD patients, emphysema, Also could be a pneumothorax. It's kind of a little bit more with the absent, really. Pleural effusion, because you just can't hear the lungs as well, because there's like fluid in between the ribs and the lung tissue itself. There's a pleural effusion there, and sometimes those need to be drained, or there could be blood in that area. And again, bronchial breath sounds can suggest an increased density, like a pneumonia. Again, crackles generally are produced by that sudden opening of the collapsed airways, or possibly with movement of excessive airway secretions. Okay, the fine crackles, so they're fine meaning that they have like a little bit of a higher pitch, I guess, and they just don't sound as wet. They're just kind of like, if you could take your hair and roll it in between your fingers, just take some of your hair and kind of roll it in between your fingers gently and put it up by your ear when you do it. That's kind of like almost like a crackly sound. Or like if you listen to Rice Krispies in the milk, that little pop, 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 that can be kind of a crackly sound. So that's your atelectatic lung, your pulmonary fibrosis, pulmonary edema. The coarse crackles, or the bronchi, are generally secretion related. Okay, so those are in your larger airways, and they can often change with a cough. Okay, so when you cough, that coarse crackle or that bronchi might go away, or it might move. Where the fine crackles, they're generally not going to move, and they're also often dependent, like gravity dependent. So if a person's sitting upright, you're going to hear them more so in the bases. If they're laying on their right side, you're going to hear them more so on their right side, especially if it's fluid, or even atelectasis, if they've been on that side for a while. And that's why it's important that patients rotate and get up and move around and stuff. Wheezes then are generally more of that kind of like a stridor, but more you can hear it in the lungs. I'm trying to mock the breath sounds for you. So there again, the vibration that's created by the narrowing of the airway, okay, through like a higher velocity. So you think about the tube is narrower and it's moving at a higher velocity. Stridor then is more in the upper airway. Stridor is often associated with labored breathing. Group patients. So here's kind of a little bit of a visual on the atelectasis. So when they're taking that, so it's kind of on the late inspiratory crackles, that's what they call it. So late on inspiration. So they inhale, and then the latter part of the cycle, as they get the breath further down into the lungs, that's pop, pop, pop when the airways start opening, the deep breath. Here is another table from your textbook. Again, just kind of just telling you the lung sound, what is the mechanism, whether it's discontinuous or whatever, and then the possible causes. Okay, so we kind of already talked a little bit about that. Make sure you review that again. All right, so bronchoscopy, I can't say that word, bronchophony, and egophony and bronchophony. Anyway, these are different kind of like sounds that you might hear. To be quite honest, I haven't heard this terminology for a while. I mean, I do know, I remember a physician over at Lutheran used to talk about whispered pectoraliquy, which is on the next slide, but hardly ever. A pulmonologist is probably your most likely candidate to really use these terms. But so basically, bronchophy is an increase in the intensity and the clarity of vocal resonance. So what it means is that you can, generally when you say something, when you're talking and you're listening to somebody's lung, you can't really hear it. It's really muffled and you can't really hear it. Okay. But if you have some type of consolidation, again, like a median for the sound to travel through or over, then you have better transmission. Okay, and that's caused generally from a consolidation. Okay, so the resultant is better transmission of the vibrations through the consolidation. So another test that they can do is have them say E, 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 and if they have consolidation, like a pleural effusion, when the patient is saying E, 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 it actually sounds like a A, 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 A. Okay, that's egophony. Okay, like I said, I've only a handful of times have seen someone actually do this or chart about it. So that's what that means. So there's some kind of consolidation that either can transmit the sound or change the sound. The other one is whispered pectoriloquy. Okay, it's another technique that's used to assess for lung consolidation. So generally, when a person whispers, you don't really hear anything. Okay, when you're listening to their lungs and you have them whispered, it sounds very muffled, low-pitched. But if you hear a high-pitched sound, that can be evidence of consolidation. So it's actually been able to travel across that consolidation. You can hear it. It's loud. So hyperinflation of your lungs or pneumothorax, bronchial obstruction, pleural effusion can reduce the transmission, basically because there's nothing for it to travel across, and so that's going to result in that decrease in vocal resonance. I know, lots of terminology here. Okay, so the DVD is called Learning Lung Sounds, but there's actually an app that they have. So if you go onto your phone and go to your app store, it's 3M Littman Learning Institute. Okay, so 3M Littman Learning Institute. And all they require for you to do is to put in your serial number, which is engraved on the head of your stethoscope, on the top of your stethoscope there. I think it's just like, I know one of my other students did it from the other class, from the group that's ahead of you guys, and it was only like 3 or 4 characters, I think, that are actually engraved in your stethoscope. I think it's a combination of a couple letters and a couple numbers, and he went ahead and just typed them in, and boom, he was able to get the app. I tried to do it. I was able to download the app, but then to go further into it, it would be $50. So I have the DVD, plus I know my breath sound. So, but check that out. I think it might be, you know, if you have a smartphone, I think it'd be worth your time to download that app and check it out. All right. So if we see lung consolidation, then we should, on percussion, we should have decreased resonance. We should have increased tactile fremitus, increased egophony, increased whispered pectoriloquy. It should be higher pitched. Chest expansion would be decreased on your affected side, and decreased breath sounds. Okay. So to add to that percussion part too, it'd be kind of more flat because there's like a consolidation there. It would not be hollow. Okay. Wrong button. Okay. Just kind of a little review. This is only a single slide on the topography of the heart. Remembering that the base of the heart lies directly beneath the middle portion of the sternum. So your heart, when you look at your heart, the base, or the bladder side, basically is really the top part of the heart as far as how it's positioned in your body, and then the apex, or the pointy part, is really the bottom part as far as the way it's positioned, and the apex then points downwards towards your left hip. Your PMI is your not PMI Medical Institute, it's a point of maximal intensity that lies mid-clavicular, near about the 5th intercostal space. So just be aware of the terminology and where the PMI is. I want to say that might be a question coming up on an exam. Neurologic exam. This is generally done by a physician, especially if they're suspecting a brain or spinal cord injury. But we need to kind of be a little bit kind of aware of what's going on, especially since it can definitely, depending on where the injuries happen, it can affect the respiratory system. So your CNS, your central nervous system, is composed of your brain and your spinal cord, and then your peripheral nervous system is the 12 cranial nerves and 31 spinal cord nerves. And this is also, I believe, in your textbook on chapter 4. Let me look really quick. Or no, chapter 5. I'm sorry, chapter 5. Chapter 4 was your vital signs. I'm just looking. It's either here or this might actually be out of Egan's. I'm looking really quick. Alright, I think it's in Egan's actually. Oh no, I went really fast. So basically, the ones that you want to be more familiar with are towards the bottom there. So you're looking at your glossopharyngeal, cranial nerve number 9, 10, 11, and 12. So the glossopharyngeal helps the tongue and the throat, so you're swallowing. That's important if that area has been affected. Your vagus nerve, that can affect your heart rate. Your 11 is your accessory muscle use in your head, your neck, shoulders, movement, and again swallowing. And then 11 being the hypoglossal would be speech, chewing, and swallowing. So just be familiar with those last 4 on that list. Glasgow Coma Scale, just to be aware, it's something that they can measure. It's something that the nurses do as part of their assessment. And you may hear them refer to a number, so you're kind of at least a little bit familiar with what they're talking about. So they give everything a score. If their eyes, if they're open spontaneously, that's a 4. If they only open to a verbal command, that's a 3. Open in response to pain, that would be a 2. And if they don't open at all, that's a 1. So the lower the score, the worse the patient's doing. Verbal response, are they able to talk on their own? Are they oriented? Do they seem confused and disoriented? Are they using inappropriate words and they're just, not able to? Are they incomprehensible sounds or no response? And then obviously motor response, can they obey commands? So you'll see maybe a nurse doing this with a patient, especially in the ICU. The general rule of thumb is, so 12 to 15 for your score is considered good. If you're in the range of 9 to 12, you should probably be in the ICU because you need closer monitoring and observation. If you're 8 or less, they say intubate. So 8 or less, intubate. So 8 and intubate kind of rhyme. So 8 or less, intubate. So then you're probably worried about whether or not they can protect their airway. So when we're talking about that abnormal flexion on the motor response, so what's going on there, or flexion or withdrawal, either one of them really, it depends when they're stimulated either to pain, or that's generally something that they kind of do, or any kind of stimulation. They may move their legs and their shoulders depending on where the injury of the brain is. So if there's a brainstem injury, it's called, which is called decerebrate posturing. Decerebrate, it's D-E-C-E-R-E-B-R-A-T-E, decerebrate posturing. So that's when that's not good to have decerebrate posturing. So it's almost like not really a seizure, but it's just like a kind of an involuntary movement that they do. Generally they're in a somewhat comatose state, so they're not following directions. But when they get stimulated, like if they get moved, or if they're doing an assessment on them, and they'll or even coughing sometimes after you suction them, they'll posture. We call it posturing. So decerebrate posturing means an outward extension of the legs and the arms, kind of like the arms will kind of rotate out, where the palms will will kind of go up and outward. And if it's more of the cerebrum damage, then it's called decorticate posturing, and that's inward posturing. So the hands kind of close, and I was talking kind of about the shoulders, that's kind of where the movement comes from. The arms kind of roll in, and the hands close, and then the legs will also rotate in. So at decorticate, the movement is towards the core of the body. So those are just different things that you'll see when you're out there. So level of consciousness, make sure you understand these terminologies, because I know there's test questions on this. Make sure you know which is which. Obviously, full consciousness, alert and awake, follows commands. It's kind of when the obtunded, stupor, these all get kind of muddled a little bit, and people have a hard time differentiating them. So lethargic or lethargy, you're drowsy, partially awake to stimuli, answers questions slowly and inattentively. Okay, so they're lethargic, but they can partially awaken to stimuli. Obtunded means they are difficult to arouse, and you constantly need to stimulate them to follow simple commands. So you constantly have to kind of poke them in the shoulder and keep talking to them if they're obtunded. They're difficult to arouse. Stupor, they'll arouse, but it has to be really vigorous and constant stimulation, meaning and it's generally painful stimulation. So if they're in a stupor, they may do that chest, where they take their knuckles across your sternum really hard and push really, really hard to kind of get them to kind of wake up. Or they might push on their toenail with like a pen, or the thing that they use to check your reflexes, the little hammer thing in the metal part. So those patients are in a stupor. And then a coma, they don't respond to anything. Okay, so just make sure you understand the different levels of consciousness. Get those down. Abdominal exam. We don't really do a lot with the abdomen, but it is important to realize that if the abdomen gets distended, or if you have abdominal surgery, it can definitely affect your breathing. Okay, people don't want to take a deep breath if their belly hurts. They don't want to, or sometimes they're limited. That's kind of like a restricted thing, a restrictive process, where their liver is enlarged. Hepatomegaly can happen with right-sided heart failure patients. If you have peritonitis, that's another thing that you'll see. It's unfortunately a little common. I think there's actually a slide on here that I need to make sure that I include, that I don't see it yet. I'll have to add one more slide about your head, neck, and eyes. Don't see it. It might come up here. We'll see it in the next slide or two. I don't think so, though. Anyway, touching. So one thing with the abdomen, and I know that this is a question. So there's a proper order of doing an abdominal exam. Okay, it's more important because touching the abdomen can change the bowel sound. So you want to inspect by looking at it first, auscultating it gently with your stethoscope, and then you start pushing on it, because touching it and pushing on the belly can change bowel sounds. So you want to perform to inspect and palpate, again, for the distension and for tenderness, because that can interfere with their breathing. Abnormal collection of the fluid in the peritoneal cavity is called ascites, and that can just get really distended sometimes with those patients, especially like peritonitis patients or patients with liver issues, and it can really impair their breathing. They really have a hard time taking a deep breath because they're restricted from, it's pushing up on their diaphragm and actually kind of move up into their chest wall, and also because it's very uncomfortable. Here is another, just talking again about some of the things that you might see in extremities, and I believe I'm going to have to add that slide as I'm looking at this. So clubbing is often seen in patients with chronic cardiopulmonary disease, where their fingers get kind of like this round club-like appearance. seen quite often in your cystic fibrosis patients, some COPD, end-stage COPD patients. You might see it, lung cancer, cyanotic heart disease. It's often associated with peripheral cyanosis, meaning they get the discolor, their extremities are generally cool, and increased capillary refill time. I need to fix that. So that means like when you push down on the nail, it's not going to refill as quickly with the blood because it should blanch briefly and then refill. And that's putting the nails together like that can kind of tell whether or not they have clubbing. If they have clubbing, they're going to have like that V-shaped. So their nail beds really aren't going to touch. And then here is that link that I was talking about. It has a lot of useful information on it. And I'm going to add that other slide here in a minute. We will talk soon, so check out for that new slide. It's going to talk about the head and the neck.